Hi there, welcome to this warm-up review. Let's get started. First question. A pregnant patient comes to the clinic complaining of new dark pigmentation on her face. What is the most likely diagnosis? So the diagnosis here is melasma. Next, a woman who is breastfeeding develops redness and swelling of her right breast. Examination shows a localized area of erythema and edema that is tender to palpation. What is the most likely diagnosis? So this is mastitis, which is typically caused by Staph aureus. Next question. A 55-year-old man who is a smoker and heavy drinker presents with a new cough and flu-like symptoms. Gram stain shows no organisms, but silver stain of the sputum shows numerous short rods. What is the most likely diagnosis? So this is Legionella pneumophila, or Legionnaire's disease. Okay, that's it for this warm-up review. Let's move on to the lecture.
In this video, we're going to talk about transplant rejection, and then we'll go over the immunosuppressants we use to prevent rejection. There are four basic types of transplant rejection: hyperacute rejection, acute rejection, chronic rejection, and then graft versus host disease, which is kind of unique. Hyperacute rejection is something you can actually see taking place in the OR. It occurs very rapidly, within minutes or maybe hours of transplanting the organ. This is an antibody-mediated type 2 hypersensitivity reaction where the transplant recipient has preformed antibodies against donor antigens, and the recipient is rejecting that graft immediately. We do all kinds of screening and matching to make sure this doesn't happen because this one's pretty preventable. Acute rejection takes longer than hyperacute rejection. Acute rejection occurs within weeks, not within minutes or hours, usually within the first 3 months or so. And this is cell-mediated, so cytotoxic T lymphocytes are recognizing that graft tissue as being foreign. In other words, the transplanted cells have foreign MHC1 molecules, so the T cells start attacking and killing the transplanted tissue. So to prevent this, or to reverse it, you give immunosuppressants, which are going to suppress that cell-mediated immunity. And one of the most common mechanisms to block this T cell-mediated rejection is to block IL-2. Because as we've discussed before, IL-2 stimulates the proliferation of all types of T cells. And chronic rejection occurs over several months to years. Now, most transplanted organs will fail eventually due to chronic rejection, but hopefully you can get 15 to 20 years of good function before that happens. Now, chronic rejection seems to be mediated by both T cells and also somewhat by antibodies. But a big part of it is that the cytotoxic T cells see transplant cells with foreign MHC1 and foreign antigens, and they treat those cells like self cells that are presenting non-self antigens. There's also some vascular damage and fibrosis of the blood vessels and fibrosis of the transplant tissue itself. And unlike acute rejection, chronic rejection is irreversible. Now, one last rejection scenario that we see usually with bone marrow transplants is called graft versus host disease. When you do a bone marrow transplant, you're basically killing all the patient's hematopoietic cells with chemo or radiation, and then you give them new bone marrow from a donor. And this grafted bone marrow is essentially giving the patient a whole new immune system. Well, graft versus host disease occurs when that new transplanted immune system attacks the host as if it recognizes the host as non-self. It's graft versus host. So the grafted T cells from this new bone marrow proliferate and they start attacking the host as foreign. This presents with a maculopapular rash on the neck and shoulders and the ears, the hands, and the trunk. In severe cases, it can kind of blister up, and it looks a lot like Stevens-Johnson syndrome. These patients also get hemolysis and jaundice and hepatosplenomegaly. They can have some GI involvement and abdominal pain and diarrhea and nausea and vomiting. Now let's talk about immunosuppressant drugs, which we use to prevent transplant rejection. Now for each of these drugs, there are two things I want you to make sure you know: the mechanism of action and the unique side effects. Focus on the side effects that are unique. All these drugs will suppress the immune system and make the patient susceptible to infection. So focus on unique side effects as well as the mechanism of action. So let's start with cyclosporin. Cyclosporin's mechanism of action is that it binds to proteins called cyclophilins in the cytosol of T cells. And then the cyclosporin-cyclophilin complex inhibits calcineurin. And since calcineurin activates the transcription of IL-2, this inhibition of calcineurin prevents the production of IL-2. So cyclosporin is ultimately inhibiting IL-2 production by way of calcineurin, and this disrupts T cell differentiation and activation. Now, when is cyclosporin used? Well, it's used to prevent transplant rejection. It's also used to treat certain autoimmune disorders like psoriasis or severe rheumatoid arthritis. Then for side effects, when you suppress cellular immunity, that's going to predispose to viral infections and lymphomas. But the unique thing I want you to remember is that cyclosporin can cause nephrotoxicity. Cyclosporin causes vasoconstriction of the afferent and efferent arterioles in the kidney, and that leads to hypertension and nephrotoxicity as side effects. The next two drugs I want to cover are tacrolimus, which is also called FK506, and there's a similar drug called pimecrolimus. Now, both of these are used topically for eczema, but tacrolimus can also be given systemically as a serious immunosuppressant for transplant rejection. Both of these drugs work by binding to enzymes called FK binding proteins, and then that complex inhibits calcineurin and inhibits the production of IL-2. Remember, shutting down IL-2 is a common theme for a lot of these immunosuppressants. And then, since these work just like cyclosporin, the side effects are a lot like cyclosporin: nephrotoxicity and hypertension. And then when you use tacrolimus systemically, it can also cause some neurotoxicity like headache and paresthesias. There's a similar drug called sirolimus, which is also known as rapamycin, and it binds to an FK binding protein as well. But the downstream effect of sirolimus is slightly different. Take a look at the study guide. Sirolimus binds to this intracellular protein called FKBP12, or FK binding protein 12, and that leads to inhibition of mTOR, which is the mammalian target of rapamycin. And ultimately, this leads to inhibition of T cell proliferation and response to IL-2. So instead of blocking the production of IL-2, sirolimus actually works on the T cells so that they can't respond to IL-2. And then for the side effects, the main thing to know is that sirolimus is not nephrotoxic. Let's talk about azathioprine next, which is a very commonly used immunosuppressant. It's a precursor of another drug you're going to need to know, which is 6-mercaptopurine, or 6-MP. So azathioprine is a prodrug for 6-MP. Both azathioprine and 6-MP interfere with the synthesis of nucleic acids. And obviously, if you can't synthesize nucleic acids, cells won't be able to divide and replicate, and immune cells won't be able to proliferate. Azathioprine is used in transplant patients, especially kidney transplants, and in autoimmune disorders like rheumatoid arthritis. It's also used off-label for a bunch of things like Crohn's disease and lupus nephritis and all sorts of different things. Then 6-MP is a cancer drug, so we're going to talk more about 6-MP in oncology. But azathioprine, because it's metabolized to 6-MP, it's going to cause bone marrow suppression because the patient can't grow rapidly dividing cells like bone marrow cells. And 6-MP, which is the active metabolite, is ultimately metabolized by the enzyme xanthine oxidase. And make sure you know that enzyme. Xanthine oxidase metabolizes both 6-MP and azathioprine. So the toxic effects of azathioprine can be increased if you're taking the gout drug allopurinol, which inhibits xanthine oxidase. Another immunosuppressant you should know is mycophenolate. Take a look in your study guide. Mycophenolate works by inhibiting inosine monophosphate dehydrogenase, and as a result, it prevents the synthesis of the nucleoside guanine. So inosine monophosphate dehydrogenase is essential in the production of guanine. If you inhibit that, you can't make guanine, and obviously you can't have cell replication. So mycophenolate prevents the rapid proliferation of B cells and T cells. It's used in transplant patients and also off-label for lupus nephritis. And the side effects aren't terribly important, but it can cause hyperglycemia and hyperlipidemia, as well as increased risk of lymphoma and infections. The next item in the study guide is about thalidomide. And we mentioned thalidomide in foundations when we were talking about teratogens. We said thalidomide was a sedative that was given to pregnant women 50 or 60 years ago, but they stopped using it because it causes phocomelia, that severe hypoplasia of the limbs. Thalidomide is one of those drugs with several mechanisms of action, but the reason we're talking about it here is that it suppresses TNF-alpha production. It increases numbers of NK cells, and it also increases IL-2 production. So in some ways, it works like an immunosuppressant. In other ways, it actually stimulates the immune system. But this suppression of TNF-alpha is useful for treating a form of leprosy, or Hansen disease, called erythema nodosum leprosum. And the enhancement of NK cell activity is useful for treating multiple myeloma, because you're stimulating the NK cells to kill the cancer cells. Now, speaking of drugs that block the effects of TNF-alpha, let's talk about infliximab and adalimumab, and then we'll cover a few more designer antibodies that we use as drugs. Infliximab and adalimumab are monoclonal antibodies that bind to TNF-alpha and take it out of commission. These drugs are particularly useful for seronegative spondyloarthropathies, psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease arthritis, and reactive arthritis, or Reiter syndrome. You can also sometimes use these drugs for rheumatoid arthritis. And then there was one anti-TNF-alpha drug that was not a monoclonal antibody. Remember what that was? Etanercept. Etanercept's a protein that mimics the TNF-alpha receptor, so it binds up all the TNF-alpha. It's called a decoy receptor. Etanercept, decoy receptor. Rituximab is a monoclonal antibody that binds to CD20, which we said was a B cell marker. Remember, B cells have CD19, CD20, and CD21. So rituximab binds to CD20 on the surface of B cells, and that induces complement to lyse the B cell. So rituximab can be used to treat non-Hodgkin lymphoma because most lymphomas are B cell tumors. There's a drug called omalizumab, which is an antibody against IgE. This can be used in severe asthma patients who aren't responding to standard treatment. But it's super expensive, so it's not really used much. Other therapeutic antibodies include digoxin immune fragments, which are actually the FAB portion of an antibody directed against digoxin. So if you have a patient with digoxin overdose that's having severe cardiotoxicity, you can give those immune fragments to bind up all the digoxin. There's abciximab, which is an antibody against the glycoprotein 2B3A receptors on platelets, which inhibits platelet activity. Now, this is used in patients that have recently had an angioplasty and stenting of their cardiac vessels, and also in patients with unstable angina or a myocardial infarction. And trastuzumab is an antibody against a protein called ERBB2 that we use to treat breast cancers that express HER2/neu. Now, for the end of session quiz, we just have one question with a whole bunch of parts. So answer that question, and we'll go over the answers together. All right, let's go over this question. Which immunosuppressant matches each of the following statements? So the precursor of 6-mercaptopurine is azathioprine, inhibits IMP dehydrogenase, that's mycophenolate, binds to cyclophilins and inhibits calcineurin, resulting in the loss of IL-2 production, that's cyclosporin, binds FK binding protein, leading to the loss of IL-2 production, it's tacrolimus or FK506, and also pimecrolimus, binds to FKBP12, leading to inhibition of mTOR and ultimately inhibition of T-cell proliferation, that's sirolimus. Used for lupus nephritis is azathioprine, and also mycophenolate and cyclosporin, off-label. And the last one, metabolized by xanthine oxidase, therefore allopurinol will increase its toxicity, that's azathioprine. And that's it for now. I'll see you next time.
Thank you. Now, here's a little obscure Irish tune called The Ballad of Mike O'Fenelate. What malignancy is associated with mycophenolate mofetil lymphoma? Oh, lymphoma. Mycophenolate increases the risk of lymphoma. And why is mycophenolate mofetil not used in pregnancy? Congenital malformations of the ear and face. Oh, trimester miscarriage. Mycophenolate mofetil is teratogen. Hey, where are you going? Come back. Oh, I can do requests. Man, I knew I should have played Stairway.